The information shared on the Allo podcast is not intended as medical advice. Your medical care decisions should be made in consultation with your physician who is familiar with your specific case.
Hi, welcome back to the Allo podcast. We are here with Dr. Tim Bahr, and we're just going to dive right back into the next question.
Yes. So the next question, this mom gave us a little bit of background about her HDFN journey. So she has anti-FYA and anti-little s. She said she had her Allo baby at 30 weeks due to premature rupture of the membranes. She said, almost immediately after birth, I met with a neonatologist here who told us about having to create or mix together blood for a transfusion. She says, I was so out of it that I wasn't sure what he meant by that. Is there a way to add certain antigens to blood for a transfusion?
Yeah, so I think what she's talking about is an exchange transfusion. And I think this highlights a couple things. You know, we have, one thing I'll highlight is one of the improvements we're trying to make in our healthcare systems here in the state of Utah is try to risk stratify moms. The reason why I need to risk stratify moms is because if they need an exchange transfusion, that is a complicated process, both on the blood bank side and on the physician side, and you need to make sure that you're delivering at a hospital that can do one. Specifically, what this mom is talking about is when we do an exchange transfusion, well, when we do regular transfusions in humans, we use component therapy for the most part, which means I'm either giving red cells, platelets, or plasma, or in some cases, cryoprecipitate. But packed red cells are not a very good exchange product when you're pulling out blood because they have a high hematocrit and they don't have any serum, or they have very minimal serum. They don't have platelets and they don't have, plasma for the most part.
Yeah, all the good stuff.
Right. So when you do a exchange transfusion, we actually have to do what's called reconstitution of the blood. So you have to take plasma.
You don't do whole blood.
No, you could. That's a whole different topic. We work in, whole blood is not a common product available in 99.9% of hospitals in the country, and we've never started using whole blood. So basically, what I'm saying is the blood bank has to make a product by taking packed red cells and mixing it. Yeah. And I think that's not an incorrect term with fresh frozen plasma. And when I call the blood bank and I ordered blood for an exchange transfusion, I actually tell them what hematocrit to mix the blood to. So my only point being is that's what the doctor was probably talking about, and that process takes time, and it's a highly regulated product when you are creating a new blood product in your hospital. And so only certain hospitals can do it, and they have to follow some really strict guidelines to make sure that it's done correctly. So I think the doctor probably talked about that because he or she was probably stressed out because of the time it takes to do that process.
That is so interesting. So do you think they take like the red blood cells from an FYA donor and an S donor, so it doesn't have to be someone that has both antigens?
So you're going to want red cells without the antigen.
I mean, okay.
Right?
That's right, yeah.
So they'll be very careful to make sure the red cells don't have any antigen.
Right,
and they'll make sure that they have plasma from a donor with a negative antibody screen.
Right.
In fact, they will use AB. They'll use AB plasma because it doesn't have anti-A or anti-B. Well, you don't have to, but I think most commonly they'll use AB plasma. It doesn't have anti-A, it doesn't have anti-B, and they'll make sure that the donor had a negative antibody screen. I can't remember all the testing steps they do prior to having that unit to make sure that it's good, but does that make sense?
Yes.
So it's actually like one of the things I ask our fellows is like, I say, I like to test our fellows on on their ability to pick the right blood product for a patient.
That's very complex.
With antigen and antibody in mind.
Wow, that's something you don't think about when you just say, I need an exchange transfusion or whatever.
Yeah.
Wow. Okay. Thank you. You're such a great educator.
No,
You know-
and blood bankers will give you the. I have a very elementary understanding of blood banking, but that's the way it works.
Yeah. I'm very interested in this one too. So here's the question. When do you like to use erythropoietin, and can you explain why it's used?
Yeah. Historically in the NICU, the NICU can be one of the highest transfusion users in the hospital, especially in depending on the hospital. And so my group are very large proponents of restricted transfusion protocols or reducing the need for transfusion.
Sure.
We have always felt like the baby's red blood cells, especially in the extremely low birth weight infant, the baby's red blood cells are better than an adult product from some random adult donor. It's a little complicated when you're talking about allo immunization, but when we think that we can avoid a transfusion that is a top-up transfusion, we will use a red cell growth factor. So either darbepoetin or erythropoietin. Erythropoietin has to be administered 3 times weekly, probably, and then darbepoetin can be administered weekly, so we prefer darbepoetin. So when do I use it? We usually won't administer it in the first couple days of life in the case of allo immunization, because when a baby produces their own red blood cells, those blood cells are antigen positive, right?
Right.
And so you have a risk of lysing those cells with the antibody load that the baby received from the mother. But after a couple days, if we think, because sometimes a kid will need the most critical time in these babies is in the first couple days when they may need a top-up transfusion or they may need an exchange. But after that, if I think I can avoid future transfusion with a red cell growth factor, then we will do so. And we will stimulate the baby's own endogenous production to produce red blood cells so that we can avoid top-up transfusions in the future.
Right. Okay. And then can you tell us what the word lysing means?
Yep. Sorry.
Yeah.
Thank you. Just breaking down or killing red blood cells. So
Right.
when an antibody attaches to a red blood cell and destroys it, or at least sometimes it doesn't destroy it, it goes to the spleen where it can be broken down or so hemolysis. Sometimes we use the term lyse the cell.
Yeah. Yes. Yeah.
Sorry, a little technical, but yeah.
No, that's good. I don't think we've ever explained that one.
Yeah.
So we don't want this baby to kind of have a boost in creating their own blood cells that are going to get destroyed and turn into bilirubin right after birth. Is that what you're saying?
Yeah. I think there's one paper, we should post it in the notes because you guys are such good readers of the literature. It was Enrico Lopriori's group in Europe.
Yeah.
And they did one randomized trial where they gave the babies darbepoetin versus not to see if they could reduce the amount of transfusions, top-up transfusions that babies born to mothers with allo immunization would need. And they did see a reduction. Some people debate that it wasn't significant enough reduction, but we do think that I wouldn't administer Darby or EPO immediately after birth, but after a couple of days, once I'm sort of feeling comfortable with the severity of the disease, if I think I can avoid future transfusions with a red cell growth factor, we will give it to try to reduce the amount of transfusions needed. I would say it's probably most helpful in mild to moderate kids, or even in the severe kid after you're sort of out of the critical first couple days.
Okay, that makes sense.
Can I make one caveat to that?
Sure.
Sometimes you guys know this, that the babies who have severe HDFN, they're already trying to crank out red blood cells as fast as possible. So this is an area of research, like most of these areas, where if a baby already has 20% reticulocytes, do they see greater benefit to more? Because what I'm trying to do is crank up the reticulocytosis.
Yeah.
Crank up the red blood cell production. Sometimes you've already maxed it out, But after birth, we definitely see a decline in that red cell production in all infants. So sometimes after a couple days, I can crank it back up and have the baby make their own red blood cells.
How often do you think this is used nowadays? Because it seems kind of like a little new here in the U.S. at least.
Yeah. We just published a survey where we randomly sampled NICUs across the country. In general, about 30% of the NICUs, 30 to 40% of the NICUs in the country use red cell growth factors, erythropoietin or darbepoetin. I think probably less of them are familiar with the use in the term HDFN patient. So uncommon.
That's interesting.
Yeah.
I wonder how often like pediatric hematologists use it, because I feel like in my case where the babies had serial IUTs and my baby's retic was like 0 for weeks.
Right.
You know, then we're definitely out of the NICU zone, and then I think that would be a good time to administer that.
Totally. If the baby, and in your case, Bethany, it was probably due to the IUFTs.
Right.
And when you give a baby a red blood cell transfusion, you will suppress their body's own red cell production.
Right.
And so you're a great case where, like, I've given this kid a lot of transfusions, but I don't want them to be dependent on transfusions.
Exactly.
And so I'm going to crank it up. So do hematologists use it? Yes, but not widely. I use red cell growth factors more than our full-time benign heme docs, the two that we have at our hospital. I use it way more than they do.
Wow.
Interesting.
So I think it just says that we need to study it more and learn how to use it more. But yeah, it was originally used in kidney renal failure patients because they erythropoietin is produced in in the kidney, and so those they have everybody in renal failure or renal transplant patients have anemia, and they were put on erythropoietin. But we've used it in babies for decades, but for some reason it hasn't gained really widespread use. And I think we have a lot of work to do in term babies, the use of these products in term babies.
I just assumed it was created in the bone marrow.
No,
That's
I think
interesting.
primarily in the kidney. Yeah.
Wow. Yeah,
EPO
you know,
is.
So
Go ahead,
if a
Molly.
mom now that someone might be listening to this and they're wondering, well, how should I know then if it's something I should advocate for my baby? Like, what should she be looking for in order to bring up, is this an option?
Well, I don't know how you guys are so awesome. I don't know how much the community pays attention to the baby's retic. Reticulocytes are immature red blood cells that indicate that the baby's bone marrow is producing his or her own red blood cells. So I think they could say if their baby is showing signs of anemia or heading towards a top-up transfusion, needing a transfusion due to anemia, I think a question they can ask is, a mom or dad could always just ask, does your hospital use red cell growth factors, or does your hospital use EPO or Darby?
Okay.
And then they'll say we do or don't, and especially if their reticulocytosis or their retic count is 1%, 0%, 2%. I'll crank the kid's retic count up to 20%.
Whoa.
With red cell growth factors. Awesome. So, like Bethany, you said you knew your baby's retic was 0, right?
Yes, because we always checked the retic with the weekly CBC.
Yeah, and that means that your baby, for various reasons, is not producing his or her own red blood cells. So that's a great candidate, in my opinion, for EPO or Darby.
Okay, great.
Yeah.
This is great. It seems to take a while for these therapies that are useful to trickle down into consistent use in hospitals and centers. It feels like that.
Especially in the case of rare disease, right?
Yeah. Do you think it's also that way
Yeah.
just in the neonatals or pediatric space too?
It is. Yeah. I mean, like I said, we've been using EPO and Darby for 20 years, but they're still
Wow.
not widespread use.
Yeah.
Like I said, 30 or
Wow.
40%.
Wow.
So it's even worse when you're talking about the
Sure,
use in
yeah.
the context of rare disease.
Right. Well, that's why we're here getting the awareness out, right?
Right.
Yeah.
Okay. Thank you for that. Should we go to the
Okay.
next question?
Yeah.
Definitely.
Okay. This next, we kind of grouped this section into some questions moms had about the time after discharge from either just birth, if they didn't go to the NICU, or if they did go to the NICU and after they're home. So this one mom, this is Jessica. She's super active on our support group. So thank you, Jessica, for these questions. She says, if a baby becomes slightly anemic, is there a threshold that should indicate going to a neonatal hematologist? Well, I guess there are very few neonatal hematologists, but hematologist. She says that she waited 6 weeks to be seen, only to be told everything was fine and to keep following up with peds, and she's still paying the bill off from that appointment. So, what's the tipping point there where someone needs to be managed by peds or by heme?
Yeah. Hopefully we'll come up with some guidelines to help guide this, because it's an art, not a science, okay? I tend to refer any kid that I think is at risk for needing a top-up transfusion to the heme clinic, to our outpatient heme clinic. So because it's pretty hard for a pediatrician to administer a red cell growth factor, Darby or EPO, and it's pretty hard for a pediatrician, outpatient pediatrician, to arrange, unless they're like right there in the children's hospital, to arrange for an outpatient red blood cell transfusion. And so, so if I think that a baby is at all at risk for needing a top-up transfusion, then I will refer them to heme. Unfortunately, it is a hard thing in pediatrics. So much of what we do is surveillance, because that's what we do as pediatricians. We prevent. And so, how many times have you been to the pediatrician where the pediatrician says, oh, just go home and watch and wait, and here's your return precautions. And so that's the criteria I use. And it's a little bit of a balance to see who needs to go to see heme and who does not.
We've seen with patients quite often where the pediatrician is handling the blood tests, but they don't get in or get set up with a hematologist. And then the baby suddenly needs a blood transfusion, and then it becomes urgent, and they're not, set up, and then it's really stressful.
Right, and it's the emergency room.
Yes, yeah.
That's why we need to work on it as a community. We talked about writing a grant so that we could have teleheme that's very specialized in this. And,
That'd be great.
Because these kids, do all. There's such a spectrum of disease. Bethany had a baby that received 7 intrauterine transfusions. We take care of about 130 moms a year in our healthcare system that have allo immunization.
Wow.
A vast majority of them have low titers and are low risk, right?
Right.
Do all of them need to see a hematologist? No. But do we need to have systems in place that can connect them with those resources? Definitely. And do we need to have a little bit of risk stratification to know who really needs it and who doesn't? Definitely. And that's things we need to work on. I need help. I need more researchers in this area.
Okay.
Because there aren't very many of us.
He's giving the call.
No, there's
Those who are listening.
Yes.
He needs help.
Yeah.
Oh, man. Okay. Good to know. Let's go to the next question. Something I've always wondered. Heel prick versus venous draw for monitoring these babies. Is it okay to do both, or is one more accurate than the other?
Great question. Your hematocrit will be higher, slightly higher, probably as much as 5%.
Wow.
1 to 2 grams per hemoglobin higher from a capillary stick. versus a venous venipuncture. where you
Okay,
actually puncture the vein.
venous. I was saying it wrong.
What did you say?
I
You
said
probably said it
venous.
right.
No, it's a word that I
Oh.
read, but I don't say in my
Oh, you're
normal
fine.
life.
That's okay.
Okay, so
There's probably people that say venous, and so
Well, maybe.
it will be higher. Which is accurate
Oh,
depends
wow,
on
okay.
what answer you want. So I think technically people think that venipuncture. So
yeah,
a
that's what
venous
I've heard.
draw from a vein
Okay.
is probably quote more accurate.
Yeah.
But that's okay. I don't completely agree with that. It depends on what you're looking for. And I
Okay.
think it's okay to do a capillary stick. In the pediatrician's office or in the NICU, we draw blood a lot of times just by capillary or heel prick.
Right.
And it'll be slightly higher, but that's okay.
Okay. It'll be higher in the heel prick? No.
It will.
Oh,
Yep.
it will be higher in the. Oh, I see.
Yep. That's called a capillary blood draw.
Okay.
And capillary blood draws will be slightly higher than a
Right.
venous or arterial blood draw.
Okay.
Our cutoffs for transfusion are, I think it's more important to look at the baby than the number alone. So that's why I'm
Okay.
okay with a little bit of wiggle room there. Is
Right.
because, what's the difference between, we usually transfuse babies around 7 grams per hemoglobin. 7 grams per deciliter of hemoglobin concentration. And I would say that, what's the difference between 7.1 and 6.9 or something like that? That's within the error of the measurement device. And so don't worry. For parents, I wouldn't worry about whether it was a capillary draw or a venous draw.
Yeah. Okay.
Yeah.
So your question, Bethany, reminded me of another question we get a lot, which is it okay to do the transcutaneous Billy readings for HDFN babies, like the sort of the light sensor Billy that they do with the little device?
Yes, it is. With a couple caveats. Most pediatricians, and most units that I've been exposed to in the United States where we have serum bilirubin testing readily available, will not base treatment decisions on transcutaneous alone. Usually they'll get a transcutaneous. If it's high, they'll confirm it with a blood test. And I completely agree with that. I don't think you're going to run across people who are even initiating phototherapy necessarily just on transcutaneous, let alone something like an exchange transfusion with transcutaneous. So, I don't think you'll come across that. I would say it's probably not the best idea to base the initiation of phototherapy or make hard decisions like exchange transfusion off of transcutaneous. And I don't think you're going to see that. That said, it is a pretty accurate way, especially if I have a kid who's already been started on phototherapy or who I'm following for day after day. Transcutaneous is a great method. It's the newest machines, and the only one that's still being produced and FDA approved in the United States is remarkably accurate. It's very, very good. Babies with HDFN, their total serum bilirubins change faster, or if you're acutely hemolyzing, it'll change faster, and the machine may not pick that up as quick. But I think generally, if you're just measuring, you're not in a sort of crisis mode and you're watching things over time, transcutaneous is a great option.
Okay.
Okay.
That makes sense. When is a baby cleared from HDFN? Like, when can we breathe a sigh of relief that we have officially graduated?
Yeah. I do like to remind my parents when they're in that extremely stressful moment that the good thing about this disease is that it is time limited. And yesterday, I can't remember if we were recording or not, the half-life of an antibody is 4 to 6 weeks. Or about 4 weeks, probably closer on the 4-week side. So once you cut the cord, the source of the antibody is no longer there, right? And so it's only a matter of time that it'll burn out. But some kids can last for a long time. Those antibodies, the load is so high, right? So when are you clear? When are you clear? Well, I've said before, I always teach people that the hyperbilirubinemia will resolve generally much quicker than the risk for anemia. So once you have a stable hemoglobin, then you're in the clear, generally speaking. And so, if you are checking weekly, some kids, we have to check more often than weekly initially, but if I'm checking weekly and I'm seeing less than a couple tenths of a gram per deciliter in your hemoglobin. So, if the baby's hemoglobin is 8.5 and I check it next week and it's within a couple tenths of a gram per deciliter of that, then you're probably looking pretty good.
Good to know. Okay.
That makes sense. Yeah.
Yeah.
Yeah, and I like your point of you need really at least 2 measurements to make that decision, I think. A lot of moms end up getting just one, just because that's the type of care that was offered or whatever, but you don't know what direction that's heading when you get just one reading. So I like that you kind of laid out a scenario of week to week what you're observing.
Correct. And it's tough. That's why I think you guys have this podcast, is it's not an easy disease to manage because of the variability in severity. And so 2 measurements when a kid's in the 14s and 15s and is 3 weeks old is different than 2 measurements at 1 day of life, right?
Yeah,
so,
true.
Yeah. And you're in the 8s at 2 days of life or something like that. Yeah.
Yeah, good point.
Yeah.
Okay, so now we're going to ask some questions about advocacy, which we love, as you know. Okay, so we already we answered this question, but I do want to ask you a slightly altered kind of question off of this one. So the original question was, can you ask to hold your baby even for 2 minutes before they are taken to the NICU? And that just made me think of, my situations with all 3 of mine. It had been very high risk, and I had lost a baby to this disease. And then I think a lot of women feel this way, where they've waited so long and they've gone through so much with this idea of like, okay, getting the baby here safely. It's kind of the goal and the dream and what they're waiting for. And so to have that moment and then not be able to hold your baby after all of that it feels traumatic. And so I remember with one of my children, we had an emergency C-section because he went into distress right before an IUT and emergency, delivery. And then my husband wasn't even there. I was alone, and they obviously had to whisk him away before I could hold him because he was in not great shape. And so I was just in the recovery room all alone. No one, nobody was with my baby, for like family wise. And I was happy that he was alive, but also just feeling sad. And somebody brought me a photo that they had taken of him in the NICU. And, he had CPAP and he didn't look great, but it was a lifeline for me, that one little photo. And I still have it somewhere here on my desk. And it was like a treasure for me. And emotionally, it was soothing. And I was wondering if most NICUs do that for moms in a similar situation with the photo. Yeah.
I wish, hearing your story, I think is very awesome. And I really appreciate that. We try to offer like, take some, I think our nurses are pretty good. Take some pictures, take them back to mom.
Yeah.
But, I think like as a community, we can probably teach moms to ask. Almost all NICUs, if a dad, or a partner or a family member is with the baby in the NICU and they ask to take pictures, I think that's very acceptable. Say, hey, mom's in the recovery room. Could I take a couple pictures and take them to her? And I think I've never heard us say no, to that. So I think that's a great thing. I think that's something we can advocate for. I think our nurses are pretty good at it, unless, crap's hitting the fan and
Sure. Yeah.
and then they might forget. But even there are moments, definitely, if I ever had a parent say, hey, mom is over there. And I think I just think as providers that's something we need to think of, and it should never be something a family should hesitate to ask about. They should ask, hey, mom's in the recovery room.
Yeah.
Can I take a picture and take it back to her? And I
Okay.
think that's completely appropriate. We should advocate for that more, and I appreciate you sharing that, because I want to do that more, because I take care of a lot of babies who are separated from their mom.
Right. And I know that the first priority is that baby's safety and immediate needs, right? So, but I think I didn't even know to ask for that. I didn't know how desperately I needed that. So I appreciate them having that thought of me back there, you know, in the recovery area. So yeah, that would be great. I think maybe even for moms who don't know to ask for it.
Yeah.
Very important.
Previously, we talked about holding, or you mentioned this mom being able to hold baby.
Yeah.
Is it okay if I comment about that too?
Oh yeah, of course. That's the original question. Sorry.
I know. So I think that's something that you should ask about early on.
Okay.
So is it appropriate? So usually a neonatologist or resuscitation team's number one concern early on is going to be the baby's ability to ventilate, to breathe, and if they can breathe, then their heart rate's going to be fine. So there will be situations, even in the term baby who has mild HDFN, that where the NICU team's going to have to intervene immediately.
Right.
Yet, a lot of our HDFN kids who are born at term are going to come out, and they're going to come out screaming, and they're going to look great.
Yeah.
And I would say that is appropriate, in my opinion, for mom to bond with the baby for a handful of minutes, maybe up to 5 to 10 minutes.
Yeah.
So I like to say that HDFN is an urgent condition that needs immediate attention, but perhaps it's not emergent if the baby otherwise is transitioning from at birth fine.
Right.
Does that make sense? So
Yeah,
maybe
that's
not.
good.
It is
Yeah, I like
urgent.
that.
It is important. It needs immediate attention by the care team. But there's a lot of things I can do while baby's being held by mom for 5 or 10 minutes before we whisk baby away.
I like what you said about kind of asking for that ahead of time. That's a really good point, and something we can kind of remind other women to do. And I did that with my daughter Nora. So my daughter Lucy died, and then after that I had Nora, and she was given a 0% chance of survival by several MFMs. And so there's all this anxiety. She made it to 38 weeks after 5 IUTs. And they were like, she could be in bad shape. We don't know. We were expecting a long NICU stay, but I asked them, is there any way I can at least just hold her on my chest for like a minute and get some photos before you take her? And they had said yes. And so that was, again, kind of like that photo. It was like a lifeline for me to just feel her. She's breathing, she's alive, she's warm, get a few photos. And you can see in the photos the NICU nurses like waiting right behind her, ready to whisk her away. And I just appreciate that so much. And I'm really glad that I had that idea to ask them for it ahead of time.
Yeah. And I love it when I'm doing a prenatal consult or to be asked that question, because it makes me think we are critical care physicians. So we go into resuscitation mode real quick. As
you should. Yes.
Yeah. But the great thing when a parent asks me that question, I have to think critically about. Usually I have to say, if this happens, but it also makes me think about very critically about the disease and, whether it is appropriate for the baby to stay with mom for a couple minutes. And I would say in most cases of HDFN, if the baby is breathing, then it's probably okay.
Yeah, that's great.
So our next question came from a mom. This is Amanda, who we interviewed this season. And she had excellent life-saving prenatal care and then delivered at a large hospital center up in Minnesota. But even throughout her son's, I think it was like more than 3 weeks into his NICU stay, they finally put HDFN in his chart that he had HDFN. And so she struggled every day with different people coming in and not knowing his treatment history and the background. So anyway, she brought up this question, but I think it's very relevant. She said, why can't we have the same doctor every day to communicate with us instead of seeing someone different every day and having no idea if they're specifically trained in the treatment of HDFN?
Yeah. Staffing ICUs is sort of a difficult thing. And so unfortunately, you're going to see a lot of turnover with your care providers in the NICU. In theory, every neonatologist should be trained in the care of HDFN. Some of us are more familiar with the disease than others. And so, unfortunately, you're depending on what kind of NICU you're in, you may have, or how they run their staffing model, you may have a lot of people, a lot of different people care for your baby. You should know that the neonatologist should be able to care for your baby. And it never hurts to ask. Like when I have a family that says, hey, we just feel like we're getting tossed around a lot, or we feel like, we're having to re-explain everything every day, I'll just tell my colleagues like, hey, can we make sure we have a consistent person caring for this baby as much as possible every day. So just ask if it seems like it's a little bit of an issue.
I also remember how hard that was because some of the neonatologists really understood HDFN and then others really did not. And I felt like I was meeting a new one every single day. And so I'm like, I don't know which one you are, and I don't know how much to advocate with each one.
Yeah, I think gently, but like we really listen to our parents, and I think in the case of like severe HDFN, they'll recognize that we don't see it as much as we used to, and so and it's been many years, but things have changed over the years. Our care has hopefully improved. And so I think if you bring it up and just say, hey, we would really like a little bit more consistency, then at least it raises a flag that says, hey, this family feels like different providers don't understand the disease. And that's okay. That's appropriate feedback.
Oh, okay. That's good to know. Okay. So the next question is, when we have a baby who did not get anemic before birth, but needs to be checked due to being Coombs positive, what can we say to the pediatrician to politely insist on regular blood checks? So this is after hospital discharge.
Yeah, I tried to write something really nice when I saw this question. Let's see. Here's what I wrote. I wrote it in quotes. Okay. I think saying something like, I know that newborns born to allo-immunized mothers may have ongoing hemolysis and may be at risk for anemia for many weeks or even months after birth. Is it possible for us to check a hemoglobin weekly for a few weeks?
That's good.
Sort of like trying to remind them, because again, pediatricians don't see this very often, even less than the neonatologists, right?
Yes.
So just stating your knowledge, hey, I know that sometimes the anemia can go on for weeks, maybe even months. Is there any way that we could check a hemoglobin weekly for a few weeks? Is it good? And again, I don't like pricking babies or poking babies, but in any case of HDFN, I don't think there's harm in checking a hemoglobin once a week for a couple weeks. Even the mildest of cases.
Yes. Yeah.
How can we explain to the team in the room at birth that it's very important to get a bili check with the cord blood? Because we've had some moms say that at their respective hospitals, they have certain protocols that they do their first bili check at 12 hours or something like that.
Yeah. So I agree that every baby with HDFN needs an immediate bilirubin check. And we will advocate for, like you said, from the cord or from the placenta. One of the hard things is there's a lot of variability across the country, especially depending on how big the hospital is, in their ability to check things from the cord or from the placenta. And to tell you the truth, some labs are more or less used to accepting cord samples. Does that make sense?
That's interesting.
So, yep. And I've had many meetings over the years about, like, do we accept this lab if it comes from a cord or a placenta? And unfortunately, it's a little complicated. What I would say is that families should advocate for a bilirubin check either from the cord or the placenta or immediately after birth.
Okay.
And they should, and so how do you do that? Say, I think you should start the conversation before delivery.
Yeah.
And, say, hey, I think it's appropriate to ask, hey, I've heard around the country that other families with fetuses affected by HDFN are able to check a bilirubin from the cord or the placenta. Do you do that in your hospital? Can you do that in their hospital? And they'll say, yep, no problem. We're going to do that. Or they'll say, they'll say, I don't know. We don't have a protocol for that. In that case, I think it's okay to check the baby within the first hour of life.
Okay.
Well, hopefully it's even sooner than that.
Yeah.
But I guess, and what I would say is that there are sometimes I'm not able to get blood from the placenta. I can almost always get it from a cord segment, but placental draws are a little bit more complicated. And so, especially in this age of delayed cord clamping. So it's just I think it's acceptable to get it from the baby immediately after birth.
Okay.
Hopefully we can do from the cord or the placenta, and we're going to write that into guidelines. But if we have to get it from the baby immediately after birth, that's okay too.
Do you think it's just as important to check the hematocrit or hemoglobin with that bilirubin as well?
Yes, I do. Yep. Yeah.
Okay.
Because we want to know where we're starting.
Right. That's, yeah. Okay.
Yeah. Yep.
All right. So I think this is our last question, although I have one quick one at the end to add.
I know.
Sorry.
I keep thinking of some,
All right,
but I'm
last
just having to.
No, you're fine.
I'm like,
I know. I'm keeping
yeah.
my eye on the clock. Okay. So this is, again, from a patient. When talking to my pediatrician before my baby is born, what are the most important things to discuss to ensure my baby receives the best care?
Yeah, I think all the things we've talked about. We live in an age now where, unless you're in a rural area, the chance that your pediatrician will be caring for your baby in the first hours of life is pretty uncommon, unless you're in a rural area. So I think you can help your pediatrician, or you can ask your pediatrician to help be an advocate, during the inpatient stay. So what things should you talk about? I think you can talk about inpatient management. Say, hey, we're really interested in, not only interested, we think it's important that we check our baby's bilirubin and hemoglobin immediately after birth. And we actually do that for all of our babies affected by Allo immunization, whether they're high risk or low risk stratification. So that, I think we can say that should be the standard of care to check, within the first hour of life or from the cord. So I say, first of all, talk about inpatient management, immediate checking. You can talk to your pediatrician about, what criteria they might use to admit to the NICU. We have some allo-immunized moms who actually don't even know if the baby's antigen positive or not yet in the milder cases, right?
Yeah.
So if, you want to get a DAT quickly, a direct Coombs test, if that's negative. So just these little details, I think it's okay to say, hey, what's going to be our immediate management? What are we going to do while we're inpatient? And then what are we going to do after discharge? And, the things we've talked about today are all things you can discuss with your pediatrician and advocate for.
And so also, I think after discharge, that would be, like you mentioned, those weekly blood checks. I think, so if we're just thinking about when the baby gets to the pediatrician after discharge, do you think that's the most important thing for the mom to kind of talk about ahead of time? Hey, we might be needing this. Is that okay?
Yes. Yep. Very good. I appreciate your specific question. So yeah, after discharge, most pediatricians will be very in tune with the management of hyperbilirubinemia. Bilirubin's a very big thing. And so but the thing that they're going to be less familiar with is late anemia of HDFN.
Right.
And so that's the thing that you can address with your pediatrician is say, hey, I'm worried that my baby will still be at risk for anemia requiring transfusion after we come home from the hospital. I know that can, like I said, I know that is a process that can continue to be,
that's a
can
good
be
phrase.
at risk for weeks
Yeah.
or months. Would it be okay with you if or is there any way that we can check a hemoglobin weekly or more frequently if needed, but at least weekly for a couple weeks after discharge? I think most pediatricians would scratch their head and say, I need to go look this up. and if they look
Which
up,
is great. I mean, that's fine.
yeah, if they look up late anemia, HDFN, they will realize the risk that's there.
Right. Yeah.
Yeah.
I love that method of sort of you're educating, but without kind of seeming too overpowering of, well, I know that this will happen, just like you know this too, which they may or may not actually happen to know.
Yeah.
But it's a great way to just
Yeah.
gently dive into that collaborative discussion. I think that's great.
Yeah. Yep.
Yeah.
Yeah. I talked to my pediatrician before my babies were born, and they were just kind of like ready for whatever, and that was very helpful. And with my last son, he had been off the lights for just a little while, and the doctors did not want to check his Billy one last time before hospital discharge. I was uncomfortable with it. They refused. They would only keep checking his hematocrit. And so that was very frustrating. But I called my pediatrician and I was like, hey, we're getting discharged and I don't feel comfortable because I don't know if he's having a bilirubin rebound. And she put in the order and we literally discharged. We drove 4 hours back to our state and went straight for that blood draw arranged by the pediatrician to check the bilirubin. And so that was really helpful that my pediatrician was ready to go and kind of like catch all the things that fell through, if anything did fall through.
Very good. Yeah, I think that's great.
Okay, last question from me very quickly. What is the difference between a neonatal hematologist and a pediatric hematologist?
Neonatal hematologist is something we made up. Oh. Sorry, I shouldn't say that. Great. So I would say that Bob Christensen is really the only true.
Wow.
I don't know. So neonatal hematology. So pediatric hematology, pediatric heme, or pediatricians that subspecialize in hematology are boarded usually in hematology and oncology. So they're grouped together.
Yeah.
At our children's hospital, we have two of those specialists who specialize in what we call benign heme, which is non-malignant, non-cancerous hematology. Okay, so that's the discipline of pediatric hematology. We've learned as neonatologists, and especially those of us who study hematologic disorders, that the diseases that affect the hematologic diseases that affect the neonate or the newborn, as opposed to the pediatric patient, can be very different. And so our research group, we study neonatal hematology and transfusion. So I think if you walk around saying, I need to find a neonatal hematology, they'll probably look at you a little bit like you're crazy. And I think technically I can say that my research and my clinical work my research definitely specializes in neonatal hematology. But because I'm a neonatologist by training, but technically I'm not a hematologist. I think hopefully that's one of the hard things about HDFN, but you should find, I think your pediatric hematologist should be a very good ally for parents in this community. They should be pretty dang familiar with this disease. And then you're going to have some neonatologists that are pretty familiar with this disease and how to manage it. But I think the reason why our group does what we do is because there is a little bit of a gap. Benign heme tends to be very focused. They do a lot of sickle cell.
Yes.
That's the number one thing that they do. And then they deal with like rare ongoing hemolytic conditions, thrombocytopenias, stuff like that. And so, this is birth hospitals aren't usually connected to children's hospitals where benign hematologists hang out. So,
Yeah.
so what's the difference? Well, there aren't very many of us that really focus on neonatal hematology.
We need
but
more.
hopefully, hopefully there's families. Hopefully families can find people who are allies and, can advocate either in the pediatric heme world, but also sort of in the neonatology pediatric world.
Right. Okay, great. Guys, I have to go.
That was awesome.
I'm sorry.
Nope. I think
okay,
I probably
let's
need to get
do
going
it.
too.
I'm sorry.
I know. No, this is so wonderful. Thank you so much, Dr.
has been
Bahr.
so
we wanted to
great.
do this since the moment we met you,
Yeah,
pretty much.
great.
We wanted to do this.
Sure.
We're like, podcast. Let's snatch him up.
Well, let's. We can do more. I can answer. We can do more in writing too,
No,
if you want more on the website.
Yeah, that's true. We
I
could
think
do more in writing.
As we
That's a good
talk,
idea.
it's very clear that we don't have great answers all the time for all these things,
Right.
right?
Yeah. I
Too much
know.
art.
We're going to get there.
We're
for our
just working
guidelines.
on it.
Yes, lots of
Yeah.
art. Whether you're a patient, provider, or otherwise affected by antibodies in pregnancy, we are here for you. We have great resources on our website at allohopefoundation.org. That's Allo, spelled ALLO, hopefoundation.org.
Thanks for listening.